Yeah, welcome in today's nursing webinar session. Myself Shanti, DVP Nursing, and today we are going to discuss about the advancement of bariatric surgery and its management. Having said so, let me welcome our expert panelist and the very beloved surgeon for the nurses, who is none other Dr. Lakshmi, and who is our senior consultant gastrosurgeon, robotic and bariatric specialist from Somajiguda Yashoda unit. And let me also welcome Kanka, who is our nurse manager from medical surgical gastro ward. So having said so, let us quickly, you can share the slide, Kanka. Let us quickly, initiate the session with first to Madam only that what is the prevalence of obesity in India, ma'am? So we would like to understand and which gender is very much impacted with the obesity. Yes.
As per statistics, we are around 3%. 3% of the population is overweight to obese. And at least 1% of them is morbidly obese.
Yes.
When we talk of 3%, 3 sounds a small number, but when 3% of this huge million population is a big number.
Yes, exactly.
So it is what we can say, uprising pandemic in our country. In Asia, actually, we can't say only to India, but in Asia, when earlier we were all fighting malnutrition, where people were starving and not getting adequate food. Now we are facing the pandemic of obesity.
As rightly said, obesity itself is a disease. I think one must always watch what they eat. So let us see what else we have the rest of the session. Kanka, you can take over with the second slide. Yeah.
Hi, good afternoon. Myself Kanka. Today we are discussing about the bariatric surgery. What is the bariatric surgery? Term refers to the treatment of obesity. Bariatric or metabolic surgery is a surgical procedure done to manage metabolic syndrome and also when ineffective diet and excessive pattern of fail.
So, ma'am, here again, as we understood what is bariatric surgery, it is none other but, metabolic syndrome and where your intervention is very much important. So, what are the, two single common factors for the rise of obesity? I know there are a lot of contributing factors.
Yes,
What are the two, at least a single one or two single factors which we should be caution about?
One is important is excessive intake of high calorie food and adapting sedentary lifestyle. So with that, small amounts of weight gain happen. But when that small amount of weight gain is happening, people don't recognize it as a problem anymore. Because now there is the word like you cannot call a person obese. So there is adequate way an obese person can fit into the society. Earlier, you were not able to buy one dress to fit anyone who is above maybe medium size. So you have to go to the tailor to get your dress stitched. But now you get dresses for 5XL, 6XL, and the plus size is advertised. So people are not willing to accept that if I gain 5 kgs and I have grown from medium to a large size dress, or I'm not able to climb 2 flights of stairs comfortably, I should look into myself and think what is going wrong. But rather, maybe they'll take the escalator which is available. There are lifts available. So that difficulty, what weight is putting on them, they're not bothered. And then you have dresses available. Okay, today medium size dress has become tight. Throw it, buy a XL dress, and till that XL dress becomes tight, I'm comfortable. So the cognizance that I need to lose weight is slowly fading off in the society. So people are very happy with their weight, happily eating, and there are enough ways by which an obese person can still be comfortable till it comes to a point of very bad health. People are not recognizing obesity.
And still we find a lot of plus size stores available nowadays. So yes, as rightly said, yes, Kanka, you can go to the next. And ma'am, would you mind to just come a little closer? Yes, if you can. Yeah, thank you. Just a little bit, yes. Kanka.
What are the indications of bariatric surgery? First, we need to go BMI. BMI is nothing but body mass index. That we can calculate it BMI, weight in kilograms by height in meters square feet. Then BMI more than 40 or BMI more than 35 within one comorbidity such as diabetic type 2. Then BMI more than 30 within the two are comorbidities such as hypertension, severe sleep apnea, CAD, or BMI more than 27.5. It is selected patients with uncontrolled diabetes.
So having understood the concept of BMI and the very common formula which is visible here, so your intervention when it comes, like these clients when they come to you with such BMI, do you primarily suggest the weight loss or they are the direct criteria for the safe surgery as per your intervention? Yeah.
No, as you said, Kanaka's sister has put out nicely the indications for surgery. Now, when a person has already reached this level, so you have to understand what is BMI 40. Means at least the person is 40-50 kgs above his ideal body weight. So someone who should be weighing 50 kgs is weighing 100 kgs. So if I sermonize them and say you do diet and exercise, are they in a fit position to do exercise? And exercise should be effective exercise. It is not that I say you walk for 1 hour and the person is dragging themselves and slowly, even if they spend 1 hour dragging themselves and walking, it doesn't come to as effective exercise. And when we use the term morbid obesity, what does morbid obesity means? It means now the obesity has become a health risk. So if a person in comparison comes to you with an unstable angina or a bad diabetes, we are not going to now preach them diet and exercise. So we are going to treat them. So obesity is also treated at par with any of these chronic lifestyle medical diseases like diabetes, hypertension, bad sugars. So you have to treat them clinically and medically or surgically. And especially as you go down the list, you see it is BMI more than 35 with one comorbidity. Yes. Means the person is obese and diabetic or obese with a cardiac disease. Now the treating physician would have already written that apart from taking my medicines, you have to medically lose weight.
Yes.
So when someone has reached this levels, we are not waiting on them. Otherwise, they'll deteriorate further. Yes. And we may lose them also because these are the people who can die suddenly and then we have lost that time. But yes, someone whose weight is creeping, someone who is between that 24 to 28 BMI and then comes to us, what should I do? Obviously, we go very strict with them, make the nutritionist take care of their dietary counseling, and we also motivate them to lose weight through exercise and an active lifestyle.
Active lifestyle, yes. Yeah.
Causes of obesity. All are no causes of obesity: high fat and sugar consumption, high alcohol intake, high protein and red meat intake, lack of physical activity, inadequate sleep, and stress.
So here we would like to even understand whether this is going to be myth or fact. Does alcohol intake, causes the morbid obesity, or, sometimes we find that, yeah, alcohol pina is causing obesity or not, which is, just common topic in the community. So what is your take on this, ma'am? Taking a lot of alcohol.
When we are talking of alcohol, we have to divide alcohol into two components. One is the effects. One is the mood elevation or the transient psychological well-being it provides. We are not looking into that factor. We are talking alcohol in terms of calories. Now, alcohol is produced from something sugary. It could be malt, it could be fruit, but ultimately it is the sugar which is fermented to give the effect of alcohol. So when you are taking alcohol, you are taking lot of sugar. So that is why people who take loads of alcohol. Now, when you talk of alcohol, there's someone who's a social drinker, maybe a little alcohol, some occasionally, sometime in a month. Now that doesn't add to your weight gain, but someone who is drinking it daily and in large quantities. Now, when people take alcohol, apart from these calories, they're binging on snacks, which is again a high calorie stuff. So the deadly combination of sugar with fried food causes weight regain.
Yes. Great to hear about, and as you have cleared the myth today, the fact you have narrated and highlighted on the fact. Thank you. Yeah.
What are the signs and symptoms of obesity? Let us we all discuss that one. Breathlessness, obstructive sleep apnea, difficulty doing physical activity, joint and back pain, low self-confidence, hypertension and hyperlipidemia, diabetic, infertility, cardiovascular risk.
So, ma'am, again, if at all we are going through a lot of, signs and symptoms, and if a primey or the one who is newlywed and she is planning for, conception, and her BMI is below or more than 30 or 35, and she comes to you. So, what guidance or what interventions do you provide, whether it is, after surgery or pre-surgery, or what risk or what, safe method do you advise to the newlywed?
Yes. If newlywed means if it's a young lady,
Yeah.
and has a lot of enough fertile life period, because now people marry late also.
Yes.
But someone who has married at a reasonable age and is willing to put some effort at losing weight through even a 10% weight loss is going to give them improved fertility. I would definitely counsel them for diet and exercise initially. But at the same time, we will have people who have been who are closer to their 40s and already morbidly obese, or people who have been married for long and tried different methods of conceiving, but their obesity is coming in their way. Then definitely, because maternal age factor is very important for during the pregnancy, we can't keep wasting the fertility time by saying keep on trying diet and exercise. For those people, surgical intervention is definitely a blessing, and but they have to wait for 1 full year till the weight loss stabilizes after the surgery. And post bariatric surgery, conceiving, childbirth, and all is equal to a normal individual, normal healthy individual. There are no problems attached with it. But because in most of the bariatric surgeries, the stomach size is reduced. So they should inform the antenatal specialist who is looking after, along with the nutrition team who is taking care of them during the antenatal period. And they will devise the diet in such a way that the small amount of extra calories which the expectant mother needs to take during the pregnancies can be adjusted into the volume of food she's eating. So the gynecologist and the nutritionist should be aware that this lady has undergone this surgery, and they will, now there is enough literature and most of the centers are well equipped to take care of these sort of ladies. So there is no trouble in that. And we have enough of our lady patients who have safely delivered babies after weight loss, giving them a chance to become a mother. And also one more important thing, what we have noticed is, if you may have an obese lady who is struggling badly to conceive and trying all sides of fertility treatments and they fail, but once they start losing weight, they conceive spontaneously. So first, weight loss is the best infertility treatment. So first lose weight, and by whatever may, either by diet, exercise, if you fail, opt for surgery, and then only go for the rest of the treatment. You will definitely succeed.
Yes, and I think the same statement goes with the PCOS also. Yes, ma'am. Yeah.
Is there any age right for the bariatric surgery? Yes. The people between the age group 60 to 17 years old can undergo for bariatric surgery.
So I think, ma'am, the adolescent bariatric surgery also is, I think, safest method, and they also opt out this surgeries. Yes.
Yes. Now, earlier, it was done under very strict guidelines, even though now also it's strict guideline, because when you are offering a child or adolescent, most of them are still not mentally strong to understand what diet and exercise. So here we need the parental intervention also. So parents should take on the responsibility of helping the child through the surgery to help them adapt the new eating lifestyle. But otherwise, we see if we don't offer these adolescents, morbidly obese adolescents, not every adolescent will need a surgery. If we leave them untreated, most of the adolescents are now becoming diabetics and developing hypertension, cardiac events at a very young age. And that is going to spoil their whole life and career. That is why few of the adolescents who are morbidly obese do need surgical interventions.
Yes. Kankavathi, you can just quickly go through the types of bariatric surgery.
What are the types of bariatric surgery? Let us discuss about the types of bariatric surgery. First one, laparoscopic sleeve gastrectomy. In this case, approximately 70 to 80% of the stomach is removed. And second one, laparoscopic gastric bypass. A small stomach pouch is made with the bypass of a small bowel, which limit the amount of food intake along with decreased absorption of food calories. Here we can see food intake also very little amount, and calories also we can take very little amount. And third one, laparoscopic mini gastric bypass done for slightly large stomach pouch. All can see that picture and that. And fourth one, intragastric balloon placement. It involves placing a fluid-filled silicone balloon in the stomach. This helps by limiting how much food can be consumed. Picture can people can understand the stomach inside. There, our surgeons or our doctors generate, and they are keeping the balloon in the stomach. According to that, stomach is cooperative. How much food we can take, that only allow for the
So
stomach.
I think these are all the very safest intervention which is given to the patient as we go through your patients. We get to having witness. So I'm sure these are all very safer surgery. But as per the Indian population, which is very safe and which is very commonly opted out, ma'am, by the Indian population.
Actually, all surgeries are safe.
Yes.
We decide the type of surgery depending upon the individual profile,
Yes.
their body mass index, their age, their eating habits, their metabolic phenomenon. On that, we decide the type of surgery. Surgeries are not selected on the basis of this is safe and that is unsafe. That is a wrong conception. The surgery is decided on the patient's needs.
Needs and BMI, all other
BMI and all that. And each surgery is very safe with a less than 1% risk profile.
Yeah, we can see, I think before you do the intervention, this is how the patient positioning is done. Yes.
So these are all surgeries done laparoscopically.
Yes.
We don't open these patients.
Yes.
And now with the robo, it is very helpful for doing super obese patients. Super obese means someone whose BMI is more than 50. You can understand when you're operating on a heavy patient, as a surgeon, when I'm operating, the whole load of the patient falls on the instruments and indirectly transmits to us. Till now, we have been doing these procedures laparoscopically, but now with us all getting robos, it becomes easy because the robo will take on the weight of the patient on itself and give me a more stable platform to do these surgeries. So with robotic surgeries, the super obese patient surgeries will become more easier for us.
So this is a very great term which we have heard today, super obese. Yes. Yeah. Good.
Preoperative instructions for the patient before surgery. High protein, low calories diet to be consumed 2 weeks PRT surgery. No smoking and alcohol to be taken. And preoperative instructions as per our doctor advised. According to that, we have to follow for the patient pre-op. like blood group, blood investigation, blood reservation, all that we can follow for the post-operative, pre-operative instructions.
Yes. Go for this 11. Yes.
Post-operative care for the patient, our nurses, how they are taking care of the patients, zero POD, IV fluid management, monitor vital signs and intake output chart, encourage the patient to ambulation, pain assessment, drain site for any using. And same time, we can discuss about the first POD of the patient care. We can start the liquid diet 20 to 30 ml per hour, continue ambulation for the patient, salt water gargling. We can prevent the throat pain or throat irritation. Spirometry every second hourly or every hourly we can encourage for the patient.
I think, yes, these are the very safe protocol which under the guidance of Lakshmi ma'am, I think this team of Somajiguda unit, they follow. Do you also wish to include any other point, ma'am, or these are all the safe protocol which is, taken for your patient?
Mainly in the post-op period, because you can see when an obese person is operated, and you should not leave them lying on the bed, because there are high chances they will develop basal atelectasis in the lungs or develop deep vein thrombosis. So that is why we adopt early ambulation. So immediately once the person is awake from the surgery, we encourage them to walk. You can see in the picture that's in the post-op where the nurse is making that person walk. It's hardly 3-4 hours after the surgery. So this reduces the chance of developing any lung or deep venous problems. And also, once you start mobilizing the patient well, their bowel movement, everything is recovery is very quick. And we almost don't starve these patients post-op period. We start giving them water on the day of surgery and start with the clear liquids from the next day. In 2 to 3 days time, they're happily tolerating around 100 to 150 ml per hour, with which they go home, and the rest of the diet management my nutrition team takes care.
So here, I think the nurses are also being taught by the clinical team and the nurse manager, who will always motivate and engage the nurses to few signs and symptoms which they see for the patients, and they should always escalate to the team, like any deviation of vital parameters, as the patient is experiencing tachycardia, shortness of breath, gradually the urine output is decreasing or drain is more than 80 ml. And if you look at the patient was very normal, but the patient is evident with a lot of unusual restlessness. Kanka, I think, do you practice these parameters, and do you get to, any opportunities where you have, escalated a few problems to madam or madam's team?
Yes, madam. When the patient is suddenly breathlessness, immediately we can start the oxygen. And when the patient is suddenly go to the urine output, it is decreased. Immediately we can inform to the consultant, madam.
Yes. So these safety precautions to be taken care. I urge all the nurses, if whoever the viewer and learner looking at this, you should always inform to the team and keep monitoring and watch over the patient. Yes. Next. Yeah, switch the slide, yes.
And here once we have to discuss about the post-surgical discharge precautions for the post-operative patients and diet pattern. First, we can encourage the patient to clear liquids and full liquid diet, soft diet, semi-solid diet, then normal diet. Then chew thoroughly, eat mindfully.
You're talking about the food pattern, right, Kanka? You're talking about the eating food pattern, madam. Right? Yes.
Yes, madam. Eating food pattern. Chew thoroughly, eat mindfully. Food portion control is must. Restricted fluid volume and timings. Vitamins and minerals supplements as advised by doctor.
Yes.
By the discharge time, the patient, we have to educate the patient. Strain exercises to be avoided for 2 weeks. Mild exercises like climbing strains allowed to them, and take shower before removing the surgical site dressing. And second hourly spirometry exercises can do. Check BP morning and evening. And at the same time, they can monitor the blood sugar levels also. Review after 2 weeks for the visiting our consultant as per the discharge summary advised.
So when they can resume their full-fledged of activities of daily living and resume the work, ma'am?
They can, we tell them by 2 weeks, they should be back to their office work, and they should start moderate exercise like walking and do breathing exercises daily. So that actually there is no restriction in activity after the surgery. The more active they are, good for us. More mobile they are, these small problems will not crop up. And once you're active, your body is active mode of losing weight, we actually assist the body to lose more weight. So the concept of rest is not encouraged in bariatric surgery. We ask them to be as active they can be and quickly return back to work.
When the patient is reported to the consultant in emergency, according to patient experience, fever, vomitings, jaundice, discharge from the surgical site, then approach to the immediately to the consultant, according to the patient experience. Who cannot allow bariatric surgery? What are the contraindications for the bariatric surgery? There are two types of contraindication for the bariatric surgery: relative contraindication and absolute contraindications. Relative contraindications: patient with end stage of kidney diseases, severe blood clot disorder, and heart diseases. Absolute contraindications: high risk for anesthesia, end stage of malignancy, substances abuse.
I think these are also managed by the clinical expertise, like madam, whether the patient is a relative contraindications and everything is set before, then you opt out for surgery. Is that so, ma'am?
Yes, we have a multidisciplinary check for all these patients before they come for surgery. They have a thorough investigation of the whole organ system. And if anything of this is found, and if they are relative contraindication like kidney disease or liver failing or blood disorders, blood clotting disorders, or a cardiac disease, we try to stabilize them before, and they come under the high risk category. Then we have absolute contraindication where we are we are not going to operate them. If someone is very high risk for, means someone has deteriorated so badly that the moment you anesthetize him, they'll succumb. We don't take upon that risk because they will anyway, they have spoiled their capacity to recover, and we intervening and adding to their morbidity is not thing. Yes. And similarly, when someone is end stage malignancy, we never do, but someone is in a treatable malignancy, we wait for them to complete their all chemos and all that, wait for a couple of years and then offer them surgery. Yes. Even substance use, alcohol use, smoking, the person should be absolutely off all these type of abuse, medication or toxic habits before they can come for surgery. So if they are not willing to give up these habits, then we don't operate them. It is not mandatory that we operate each and everyone who comes to us with obesity. So these are the few relative and absolute contraindications. And also someone who is actively pregnant, someone is pregnant and obese, we don't offer them bariatric surgery. We wait for them to complete their delivery, let them finish their lactation, then only we get the mother back if she still requires a bariatric surgery that time.
Yes. After surgery, the patient will get any benefits for the bariatric surgery. Let us discuss about that. Improved lifespan, long-term resilience of diabetic type 2, improve cardiovascular health, relief of depression and obstructive sleep apnea, joint pain relief, improve fertility. These are benefit for the after post-operative and after surgery for the people who are undergoing for the bariatric surgery. This is the benefit for the patients. Drawback, weight regain or permanency.
So, ma'am, if at all the drawbacks, we wish to know that weight regain, or if at all it is going to be a permanent, do they still come for your intervention for redo or some other lifestyle changes or anything else? We wish to know from you. Yes.
See, mainly once surgery is done, we motivate the person to adapt a healthy lifestyle to maintain that weight loss. But there are some people who are not falling into the track, and they may still be eating very high calorie diet and not maintaining a healthy, they may come back with the weight regain. Yes. But coming back to the total previous weight is very rare. Maybe 5 to 10% may fall into that track. For those people, we have to see what went wrong, whether the person has not changed his lifestyle, or is there a technical issue? Means if a super obese person has undergone only a restrictive procedure, the restrictive procedure will not give the adequate amount of weight loss. Then maybe we have to convert them to a malabsorptive procedure to increase their weight loss. Or sometimes with passage of time, some people do gain back some weight. But if it's a 10-15 kgs excess weight gain, then we can always use the newer drugs which are available, the GLP analogs which are available, to help them to lose further weight. But if it is a behavioral disorder which has led to weight regain, we don't jump on to treating the weight regain, but first try to correct the behavioral disorder which has led to this whole thing, and then think of correcting the weight regain.
So I think the day by day, the dynamics of weight loss interventions are becoming very popular, and populations are getting benefit out of it. Yes. So Kankar, we have come to the end of session. You can just share this slide, and here we talk about the conclusion. And as bariatric surgery giving a long-term tool weight management, and surgery can restrict the quantity of food body can handle, but we all know that what we need to watch what we eat. Actually, one has to be really disciplined about what they eat. So you would like to just give any note to the learners, ma'am?
Yeah, mainly bariatric surgery is a tool to help you to lose weight. Okay. But it is also a commitment on that individual person that I need to lose weight, I need to maintain my weight loss. So if someone is not motivated, which you can make out by talking to them, we ask them to first try diet and exercise. So they should understand how difficult it is to lose weight with diet and exercise. And then if they need counseling sessions, we first put them through that and then get them for surgery. So surgery is one good tool. Use it to optimally and use it to the best and maintain the results is what I tell each and every person whom we offer this surgery. And it's very mandatory that they have to get into the healthy track to maintain their health.
So that's how they boom with their lot of confidence, self-impact, I think. Yes. Having said so, we end the session, and thank you so much. We were very privileged and honored to have you with us today. I'm sure we look forward to have more session with you. And thank you, Kanaka. We end the session here. Thank you so much.
Thank you.